Parkinson's disease begins with a stark statistic. About 1 in 100 older adults will face it, and it reaches beyond tremor. Movement slows, sleep fragments, mood and thinking wobble, and everyday autonomy erodes. The harsher truth is timing when symptoms become visible. More than half of the dopamine neurons in a tiny midbrain, cite the substantia nigra pars compacta, may already be gone. Treatment often starts late. Levodopa changed that early part of the story. Replenish dopamine and movement flows again. The body seems to remember its rhythm. Yet 5 to 10 years into therapy, the same medicine can provoke involuntary dance-like movements, L-dopa-induced dyskinesia. That paradox, described by Stanley Fahn in 2000 and reinforced by Müller and Russ in 2006, pushes a sharper question. Can we move beyond chasing symptoms to slowing or preventing neuron loss? The cellular narrative snapped into focus in 1997 with two converging discoveries. Polymeropoulos and colleagues linked alpha-synuclein gene mutations to familial Parkinson's, and Spilantini and colleagues showed alpha-synuclein is a core component of Lewy bodies inside degenerating neurons. One culprit, 2 lines of evidence misfolded, aggregated alpha-synuclein jams, neuronal machinery, and drives degeneration. Threaded through these same circuits is the brain's cannabis-like control network, the endocannabinoid system. In 1992, Devane and colleagues discovered anandamide, and in 1995, Sugura and colleagues identified 2-arachidonylglycerol. These natural messengers act at CB1 and CB2 receptors to tune movement, mood, pain, and inflammation, the very dials that drift in Parkinson's. If those dials shift with disease stage, carefully nudging them might help. Evidence that the dials do shift appeared soon after. In 2000, DiMarzo and colleagues reported elevated endocannabinoids in basal ganglia regions in Parkinsonian models, suggesting that cannabis-like tone ramps up as movement circuits falter. In 2001, Lastris Becker and colleagues observed increased CB1 receptor binding and stronger downstream signaling in the caudate and putamen of people with idiopathic Parkinson's. Not every arrow pointed upward. In 2003, Hurley and colleagues found reduced CB1 mRNA in several basal ganglia nuclei from Parkinson's brains, and in 2012, Van Lera and colleagues imaged 29 patients and saw lower CB1 availability in the substantia nigra region. Method and crucially disease stage help explain the mixed CB1 picture. On CB2, the trend is clearer. In 2015, Garcia and colleagues identified CB2 receptors in human nigral neurons, the very cells that die. In 2016, Gómez-Gálvez and colleagues reported higher CB2 expression in the Parkinsonian substantia nigra after death, prominently on IBA1-positive microglia, the brain's immune sentinels. Where inflammation is active, CB2 gathers, hinting at a lever for calming harmful immune responses. Fluid biomarkers echo the dynamism in 2005 and again in 2010. Pisani and colleagues measured elevated endocannabinoids in the cerebrospinal fluid of untreated patients, more than double controls in one report, and showed those levels normalizing with chronic dopaminergic therapy. The endocannabinoid system bends with both disease and treatment. Why might cannabinoids matter here? Consider the forces that push these neurons toward loss. In 1998, Hampson and colleagues showed that CBD and D9-THC bear phenolic groups that make them potent antioxidants. That chemistry matters because Parkinson's neurons are battered by oxidative stress from mitochondria and even from dopamine's own metabolism. Neuroinflammation amplifies the blow-activated microglia release. Inflammatory molecules such as TNFA and more reactive species, harming nearby neurons and recruiting still more microglia in a self-sustaining loop. Mitochondrial dysfunction, especially at complexes I and the 3, adds to the oxidative burden. In 1999, Doble described how excessive glutamatergic signaling excitotoxicity overloads neurons, and alpha-synuclein, as those 1997 studies taught us, misfolds and aggregates, jamming protein handling systems. 5 overlapping pressures: oxidative stress, inflammation, faulty powerhouses, excitotoxic noise, and sticky protein. Aggregates converge on the same vulnerable cells. Within that storm, levodopa still works brilliantly at first. Arvid Carlson summarized the logic in 2002 Supply. A dopamine precursor and basal ganglia circuits briefly rebalance, movement becomes smooth again. Over years, though, the circuitry adapts in maladaptive ways, and dyskinesia becomes the price many pay for continued benefit. That is where cannabinoids re-enter the conversation. Can they help with motor symptoms, relieve non-motor burdens like psychosis and sleep disruption, and most ambitiously protect neurons? On bradykinesia and rigidity, a counterintuitive idea came from preclinical work. In 2005, Fernandez Espejo and colleagues tested CB1 antagonists, such as rimonabant, in animal models, and saw improved motor performance, particularly in severely lesioned animals. If CB1 activation tends to dampen movement, dialing that signal down can in some contexts lift the brake. A broader view arrived in 2022, when Irby and colleagues meta-analyzed animal studies on the rotarod cannabinoids, improved performance by roughly 30 seconds on average in MPTP models. The gain was about 26 seconds with statistical significance. In the pole test, descent time dropped by about 1.5 to 2 seconds. Yet open-field locomotion often showed no clear benefit. The practical reading is straightforward. Cannabinoids can help specific task-level motor behaviors in models, but they are not a universal switch for movement. For levodopa-induced dyskinesia, the record splits between clinic and lab. In 2001, Sirodzan and colleagues ran a pilot in which nabilona, a CB1 active drug, reduced dyskinesia in 19 patients, an encouraging clinical signal. In 2004, Carroll and colleagues conducted a 4-week randomized, double-blind crossover, using a THC CBD extract in 24 patients and saw no dyskinesia reduction. In animals, the pattern is stronger and mechanistically cleaner. In 2002, Fox and colleagues showed nabilone reduced dyskinesia in primates. In 2003, Ferrer and colleagues showed Win55-212-2 reduced dyskinesia in rats, and blocking CB1 erased the benefit, confirming CB1 mediation. In 2016, Dos Santos Pereira and colleagues found that combining CBD with a TRPV1 blocker reduced dyskinesia in mice. The mismatch likely reflects dose, formulation, timing relative to levodopa, disease stage, and trial design. The next steps are standardized compounds, careful staging, and trials powered to detect realistic effect sizes. Parkinson's also burdens people with psychosis, disrupted sleep, anxiety, and pain. Here the signal tilts towards CBD. In 2009, Zuardi and colleagues reported that about 300 micrograms a day of CBD may reduce psychosis in an open-label study. In 2014, Chagas and colleagues published 2 exploratory studies. One found that CBD eased complex behaviors in REM sleep behavior disorder, and another suggested improvement in overall quality of life at similar doses. Patient surveys by Venderova in 2004 and by Lotan in 2014 echoed subjective gains in mood, sleep, and pain with cannabis use. In 2019, Peeble and colleagues reported that nabilone may help selected non-motor symptoms in a randomized, placebo-controlled setting. These data are early, not definitive, but they position CBD as a pragmatic candidate for psychosis and sleep problems, while larger controlled trials are built. The most hopeful question is whether cannabinoids can protect neurons, not just soothe symptoms. In 1998, Hampson and colleagues showed CBD and D9-THC are potent antioxidants, sometimes independent of CB1 or CB2 via direct scavenging of reactive species. In 2005, Lastras Becker and colleagues showed CBD protected against 6-OHDA toxicity in cells and animals, and in lesioned rats, D9-THC's protective effect persisted for weeks after stopping treatment, hinting at durability. On the immune axis in 2011, Garcia and colleagues activated CB2 with HU308 and observed less nigrostriatal loss and better neuron survival in LPS lesioned mice. In 2016, Gómez-Gálvez and colleagues reported that selective CB2 activation reduced INOS gene expression in the striatum, targeting a key inflammatory enzyme that fuels nitrosative stress. There are even hints of repair. In 2006, Palazuelos and colleagues, and in 2007, Molina Holgado and colleagues reported that CB2 agonists stimulate neural progenitor proliferation, and in 2007, Aguado and colleagues showed CB1 activation can promote progenitor proliferation after excitotoxic injury. Whether those proliferative sparks translate into meaningful human recovery remains uncertain, but the path is plausible. 3 takeaways tie this together. First, cannabinoids are not one thing, and Parkinson's is not one stage. The endocannabinoid system shifts over time. so the useful lever may differ early versus late. Second, the most actionable near-term signal is CBD for non-motor. Symptoms, psychosis, and REM sleep behavior disorder around 300 milligram a day. In exploratory work with a favorable safety profile, but a clear need for larger randomized trials. Third, if disease modification is the goal, CB2 selective strategies paired with antioxidant scaffolds inspired by CBD and D9 THC deserve Phase 2 trials with validated biomarkers and meaningful functional endpoints. Until those answers arrive, the practical path is to use what looks ready and build the careful studies that can tell us whether these approaches can change the trajectory of the disease, not just the day-to-day experience. In sum, cannabinoids offer clues for symptom relief and neuroprotection, but careful trials must confirm their value. Thank you sincerely for listening.